Thyroid disorders. What to look for in hypothyroidism and hyperthyroidism. Hyperthyroidism, bradycardia, constipation, weight gain, fatigue, lethargy and coma, decreased reflexes, cold intolerance, hypothermia, hair loss and erythema. Hyperthyroidism, tachycardia, palpitation, arrhythmia and atrial fibrillation, tachycardia, hypertension, weight loss, anxiety, nervousness and restlessness, hyperreflexia, heat intolerance and fever. Hyperthyroidism almost always has a single cause, failure of the thyroid gland due to burnt-out hyperparathyroidism. The acute phase is rarely perceived. Occasionally, hyperthyroidism is caused by amiodarone or diary deficiency of iodine. Now, how do you diagnose hyperthyroidism? Hyperthyroidism is characterized by almost all bodily processes being slowed down except menstrual flow, which is increased. When TSH is very high, more than double the upper limit of normal, when the normal T4 with normal replaced hormone. When TSH is less than double the normal, get antithyroid peroxidase, that's antithyroglobulin antibodies. If the antibodies are positive, replace thyroid hormone. Diagnostic testing for hypothyroidism starts with TSH. If TSH is suppressed, measure free T4. If TSH is marked in red, the gland has failed. Treatment is replacement of thyroid hormone with thyroxine. Now, high TSH double normal plus normal T4 give treatment. Antithyroid peroxidase antibodies tell who needs thyroid replacement when T4 is normal and TSH is high. Then Euthyronic hormone is a condition in which clinically euthyroid patients with normal non-thyroidal symptomatic systemic illness have low serum levels of thyroid hormone. T3 is low, reverse T3 or T3 is high, and T4 can be low. The mechanism of this abnormality is that T4 is converted to R T3, which is inactive, instead of T3, which is very active. The key is that TSH does not rise, so it is not real hypothyroidism. Euthyronic syndrome is not the same as subclinical hypothyroidism, that is elevated TSH with normal T4 and T3, and no symptoms is sometimes treated. Real hypothyroidism has very high TSH, Euthyronic syndrome does not. Treatment of Euthyronic syndrome is directed towards the underlying illness. Thyroid hormone replacement is not indicated. Do not order thyroid function test in patients with non-thyroid critical illness. Results will not be accurate. Hyperthyroidism. Etiology. What is the most likely diagnosis? Diagnosis: unique feature. Graves' disease, high proptosis, 24%, and skin findings, breath. Subacute thyroiditis, tender thyroid. Painless silent thyroiditis, non-tender, normal exam results. Exogenous thyroid hormone use, involuted gland not palpable. Pituitary adenoma, high TSH level. Now, only Graves' disease has eye and skin abnormalities, TSH receptor of antibodies. Diagnostic testing includes TIT4 thyroxine, elevated in all forms of hypothyroidism, TSH elevated in pituitary adenomas, but decreased in all others. Thyroid antibodies, name, yeah, thyroglobulin, detect recurrence of thyroid cancer. Thyroid stimulating hormone, immunoglobulin, TSI, confirmed Graves' disease, not positive and proximal multilocular corridor. Thyroperoxidase antibody TPO, confirmed presence of Hashimoto's thyroiditis. Lab findings in hypothyroidism. Diagnosis: TSH, RAIU, and confirmatory. Graves' disease, low TSH, RAIU is elevated, and positive antibody testing. Subacute thyroiditis, TSH is low, RAIU is decreased, and tenderness on palpation. Painless silent thyroiditis, TSH is low, RAIU is decreased, and confirmatory on no confirmatory. Exogenous thyroid hormone use, TSH is low, RAIU is decreased, history and involuted non-palpable gland. Pituitary adenoma, TSH is high, RAIU is not done, and MRI of the head is confirmatory. Toxic nodule, TSH is low, RAIU is increased, and confirmatory focal areas. TSH level is used to monitor hypothyroidism. In hypothyroidism, however, free T4 levels are used to monitor the disease because TSH lags. Toxic nodule has focal uptake of radioactive iodine. CRAVE is diffuse. RAIU is radioactive iodine uptake. The treatment is as follows: Graves' disease, methimazole or propylthyroxine, then radioactive iodine. Subacute thyroid is aspirin. Exogenous thyroid hormone use is stop use. Pituitary adenoma is surgery. Acute hyperthyroidism and thyroid storm. Propranolol blocks thyroid organ effect, inhibits peripheral conversion of T4 to T3. Thyroiduria drugs, methimazole preferred or PTU preferred only in pregnancy, block hormone production. Adenine contrast material, panoic acid and ipodate blocks the peripheral conversion of T4 to the more active T3 or blocks the release of existing hormone. Beta blocker may always be given before iodine replacement. Steroids, hydrocortisone, inactive iodine, ablates the gland for a permanent cure. Give on thermopathy, steroids, best needle therapy, have no response. Radiation is used, severe cases may need decompression surgery. Pregnant silent thyroiditis require no treatment. Amiodarone always gives thyroid abnormalities either high or low. Now, thyroid nodules, papillary is the most common and aplastic is most lethal. Thyroid nodules are very common and are palpable in as much as 5% of women and 1% of men. The vast majority of cases are benign adenoma, colloid nodule, and cyst. There is rarely an association with clinically apparent hyperfunctioning or hypofunctioning. For 6-year-old woman presents with a small mass she found on papillary of her own thyroid. A small nodule is found on the thyroid. In the thyroid, there is no tenderness. She is otherwise asymptomatic and uses no medication. What is the most appropriate next step in management? See T4 and TSH levels. If the patient has a hyperfunctioning gland, that is the T4 is elevated or the TSH is decreased, the patient does not need immediate biopsy, and she is not hyperfunctioning, or sound of the thyroid is done to elevate the size of the lesion but do not change the need for either thyroid function testing or needle aspiration. No, needle biopsy is the mainstay of thyroid nodule management. Diagnostic testing includes biopsy with fine needle aspiration for thyroid nodules greater than 1.5 cm of patients have normal function, thyroid function, T4 or TSH. The ultrasound and radionuclide scans are not needed because they cannot exclude cancer. When a patient has a nodule, one perform thyroid function test, TSH and T4. Two if tests are normal, biopsy the gland. Now, a 46-year-old woman with a thyroid nodule is found to have normal thyroid functioning on testing. The fine needle aspirate comes back as indeterminate for follicular adenoma, with most appropriate next step in management, P. Surgical removal, excision biopsy. A follicular adenoma is a histologic reading that cannot exclude cancer. The only way to exclude thyroid malignancy is to remove the entire nodule. This is an indeterminate finding on a fine needle aspiration. A sonogram can exclude cancer. Calcitonin levels are useful if the biopsy shows biliary carcinoma. Calcium disorders, hypercalcemia. Most patients are asymptomatic. Causes include primary hyperparathyroidism, most common cause, vitamin D intoxication, hyperketosis, and other granulomatous diseases, thyroid diuretics, hyperthyroidism, metastasis to bone, and multiple myeloma. Primary hyperthyroidism and cancer account for 90% of hypercalcemia patients. Those who are symptomatic likely have cancer and hypercalcemia malignancy caused by a PTH-like particle due to severe acute symptomatic hypercalcemia. In those cases, symptoms include confusion, stupor, and lethargy, constipation, cardiovascular short QT and hypertension, mechanism not clear, bone lesion, osteoporosis, renal nephrolithiasis, diabetes insipidus, and urine insufficiency. Treatment for acute hypercalcemia is as follows: saline hydrated at high volume, bisphosphonates, pamidronate, and zoledronic acid. Calcitonin works faster than bisphosphonates. Prednisone when the cause is sarcoidosis or any granulomatous disease. Now, a 75-year-old man with a history of malignancy admitted with lethargy, confusion, and abdominal pain. His calcium is found to be markedly elevated. After 3 years of normal saline and zoledronic acid, his calcium still markedly elevated the next day. What is the most appropriate next step? A. Calcitonin. Calcitonin inhibits osteoclast. The onset of action of calcitonin is very rapid and it wears off rapidly. Bisphosphonates takes several days to work. Plicamycin and Kalium are older therapies for hypercalcemia that are no longer used when given and answer choices for treatment. They are always wrong. Pamidronate is a bisphosphonate and does not need anything, not the use of zoledronic acid. Calcium would be used only in those in renal failure. For those in renal failure, Quinaselset is an inhibitor of PTH release. If the hypercalcemia from malignancy, PTH should already be maximally suppressed. Furosemide is not used when urine output is adequate with hydrated alone. Hyperparathyroidism. Primary hyperparathyroidism is from solitary adenoma 80 to 85%, hyperplasia of all four glands 15 to 20%, parathyroid malignancy 1%. Primary hyperparathyroidism often represents as an asymptomatic elevation in calcium levels found on routine blood testing. When there are symptoms, it can occasionally present with the sign of acute severe hypercalcemia. Usually described more often, there are slower manifestations such as osteoporosis, epilepsy, urinary deficiency, muscle weakness, anorexia, nausea, vomiting, and abdominal pain. Like alcohol disease, calcium stimulates gastrin. Besides high calcium and PTH levels, you will also find a low phosphate level, high chloride level, EKG with a short QT, and sometimes an elevated bun and creatinine. Alkaline phosphatase may be elevated from the effect of PTH on bone. Bone X-ray is not as good test for bone effects of high parathyroid hormone. Texture geometry is better. Tip: Preoperative imaging of the neck with sonography or nuclear scanning may be helpful in determining the surgical approach. Treatment: surgical removal of the involved parathyroid gland, standard of care, indication of removal of parathyroids, bone disease, example osteoporosis, knee involvement including stones. Age less than 50 years, calcium level consistently 1 point above normal, When surgery is not possible, give finasteride which inhibits release of parathyroid hormone. Acetylsalicylate is used for secondary hyperparathyroidism. Hypocalcemia.